So I invite Dr. Sheila Mane, the consultant, Anugrah.
So compression suture, I think every one of you are doing it. There is not that, I mean, most of us have learnt it now over a period of time. But what is important is that the decision making. Because when the medical management is not working, you have to take a decision to surgery, and that is important. So the decision making is very important in postpartum hemorrhage, because not only the mortality, we also want to avoid the morbidity, because the blood and blood products are not easily available in our country. So a stitch in time saves 9. Yes, if there is a traumatic PPH, we will secure the bleeder. But if there is a atonic PPH, now you will see that there is a code H mentioned there. So I just thought of having a H code for hemorrhage, because when we say that 40% of mortality is due to PPH, most of the mothers are dying due to PPH in our country, but not due to any cardiac problems or anything. Okay, we are prepared for code blue, then why we shouldn't be prepared for code H? So coming to this, now this algorithm for management of atonic PPH, that is hemostasis, that is the hemo mostly concentrates on the conservative and the medical management. We have to ask for help, assess the parameters, establish the etiology, ensure availability of blood, massage the uterus, and oxytocins to be given. Then the algorithm for management of atonic PPH, if we talk of stasis, again the shock garment, shift to theater, exclude tissue or trauma, bimanual compression, tamponade, and then if this has not worked, then we come to compression sutures. Now we have many compression sutures, and I think the other speakers are going to talk about that. Dr. Sushila already told you about beautifully about the assessment of blood loss, which is very important when we are assessing the vitals. Now arresting the bleeding. The commonest cause is the uterine atony, because uterus blood supply 70% comes from the uterine artery. And clinical examination must be undertaken to exclude the other causes, like we will have to rule out, see what is the cause, that is the 4 T's. Either retained products or a trauma, rupture uterus, broad ligament hematoma, or a extragenital bleeding. So uterine atony. So the B-Lynch is the surgical procedure. Now going to the clinical points. It's a user-friendly suture material we have to use. We can use monocryl #1, or now what we are using is the what we call it as Vicryl, 19 centimeters curved, and Ethigard blunt needle. Other rapidly absorbable sutures can be used according to the surgeon's preference. Good length and needle are essential. Basic surgical competence is required. Uterine cavity is checked, explored, and evacuated. Suture bends maintain even and adequate tension without uterine trauma or shouldering, because when we are applying the suture, it should not cause trauma to the uterus. Allow free drainage of blood, debris, and inflammatory material. Transverse compression suture is applied to the lower segment for abnormal placentation, also effectively controls bleeding. That is ischemic transverse sutures for the lower segment. And all these are simple, effective, and cost saving. Fertility is preserved and proven. Mortality is avoided. And there is a worldwide application and successful reports from B-Lynch, and the personal data is available. Now the potential for prophylactic application at cesarean section when signs of imminent PPH develop, for example in placenta accreta, or where blood transfusion is declined, or in placenta previa surgery, or on a patient of Jehovah's Witness who refused to take the blood and blood product. So there it can be used prophylactically. Now coming to the principle of B-Lynch suture. The suture aims to exert continuous vertical compression on the vascular system. In the case, the postpartum hemorrhage from placenta previa, a transverse lower segment compression suture is effective. The technique, surgeon's position right hand side of the patient, lower segment transverse incision. If we are doing after a vaginal delivery, laparotomy is always necessary, and you must exteriorize the uterus. The test for potential efficacy of the B-Lynch is before performing the procedure. That is, you will have to compress it like this anteroposteriorly, that is the tamponade test you have to do to see that it is going to really help. Now the Lloyd-Davis or semi-lithotomy position, B-Lynch prefers that to check, because when you are applying the suture, whether the blood loss has stopped. Assistant stands between the patient's leg and swaps the vagina to check the bleeding. Uterus is again delivered out and bimanual compression is performed. If the bleeding stops, good chance that Behlen's suture will work. It is not a substitute for medical treatment or coagulopathy, which should take place along with operative intervention. Application: senior assistant performs compressions and maintains it during the placement of suture. First suture is placed 3 centimeters below the cesarean or a hysterectomy incision on the patient's left side. That's what Behlen prefers, traded through the uterine cavity to emerge 3 centimeters above the upper incision margin, approximately 4 centimeters from the lateral border of the uterus. The fundus now. The suture is now carried over the top of the uterus and to the posterior side. Once situated over the fundus, the suture should be more or less vertical and lie about 4 centimeters from the cornu. It does not lend to slip laterally towards the broad ligament because the uterus has been compressed and the suture milked through, ensuring that proper placement is achieved and maintained, and we have to maintain the tension from the beginning. The posterior wall, the location on the posterior uterus where the suture is placed through the uterine wall is actually easy to surface mark posteriorly. It is on the horizontal plane at the level of the uterine incision at the insertion of the uterosacral ligament. Role of the assistant continues to compression, helps to pull suture material without breaking it. The fundus, as the needle pierces the uterine cavity side of the posterior wall, it is placed over the posterior wall, bringing the suture over the top of the fundus and onto the anterior right side of the uterus. The needle re-enters the cavity exactly in the same way as it did on the left side, that is 3 centimeters above the upper incision and 4 centimeters from the lateral side of the uterus, through the upper incision margin into the uterine cavity, then out again through the 3 centimeters below the lower incision margin. Later, the role of the assistant maintains the two ends of the sutures are put under tension and a double throw knot is placed for the security to maintain tension after the lower segment incision has been closed by either the 1 or 2 layer method. So you put a double throw and wait, the assistant waits and then you close the uterus, preferable to ligate the angles before we start the procedure. Relation to the hysterectomy incision, the tension on the two ends of the suture material can be maintained while the lower segment incision is closed, or the knot can be tied first, followed by the closure of the lower segment. If the latter option is chosen, it is essential that the corners of the hysterectomy incision be identified, or LSCS incision, and stay suture placed before the knot is tied, and this ensures that when the lower segment is closed, the angles of the incision do not escape it. Post-application and hysterectomy closure, it is probable that the maximum effect of the suture tension lasts for only about 24 to 48 hours. Application after normal vaginal delivery, if laparotomy is required for the management of atonic PPH, it is necessary to do hysterectomy to apply Behlen. It will also allow to explore the uterine cavity, exclude the retained products, evacuate the large blood clots, and diagnose abnormal placentation, decidual tears, damage, and bleeding. Behlen suture application or any modification of it without hysterectomy or reopening the cesarean section, according to Behlen, runs the potential risk, but we know that it was modified. Now, application for abnormal placentation, the Behlen suture may be beneficial in cases of placenta accreta, percreta, and increta in a patient with placenta previa if a figure of 8 or transverse compression suture to the lower segment, anterior or posterior compartment, or both is applied to control the bleeding. If this is not completely successful, then in addition, the longitudinal breast suture component may be applied for further complete hemostasis. Now in 1994, Behlen introduced this breast suture, and in 1997, the transverse suture for the lower segment was, I think, came from Behlen. So this is the way we put. We can take point A where we start, point B where we come out on the anterior wall, go across the fundus, C and D are on the posterior wall, and again E and F are on the anterior wall. So this is the uterine compression suture where the cavity is not closed. I had the opportunity to invite Behlen to Bangalore when I first conducted the PPH workshop and it started, and I must thank Dr. Bellad if he is there, because I met him in Figo in Cape Town, and then we thought of inviting him, and he himself was here to demonstrate this. So the combined application also can be tried with B-Lynch. That is, we can use a uterine sandwich technique where even the balloon tamponade can be used. We can use it here only because the cavity is not obliterated, and a balloon can be inserted, inject only 100 ml of normal saline, and then close the uterus, and then again inflate the balloon. Now, the B-Lynch procedure was modified by Richard Heyman and Professor Arul Kumaran. There was no lower uterine segment incision if it was following normal delivery. Number 2, Vicryl were used. Straight and blunt needle used to transfix the uterus from front to back just above the reflection of bladder. And this was the comparison done between the B-Lynch procedure and modified B-Lynch, but many people may not agree for that. The one thing is that the Heyman's procedure becomes easier, and when there is lot of oozing, I think, when there is lot of oozing from the decidua, from the cavity, I think the Heyman's suture really helps because it helps to compress the uterine cavity. Once when I was doing a cesarean on a patient who had to undergo consequently, I mean, together the heart surgery, the patient was hyperonized. I had to just pack the uterus, deliver the baby, and wait for 4 hours till they finished. When I come back, because there was a lot of oozing, so that moment I referred that the Heyman's is better. Now, Heyman's add to more available method for conservative surgery, and it is ideally in non-cesarean cases. So I will not, I don't think there is a time to show the videos. We had a demonstration yesterday. So I will go ahead with this. So this was the Heyman's modification of B-Lynch suture. And lower uterine segment is not opened, uterine cavity not explored, probably quicker to apply, but there are no feedback that on fertility outcomes. And unequal tension leads to segmental ischemia, secondary to slippage of suture. So shouldering with venous obstruction. So in both these compression sutures, we have to take this that there should not be a unequal tension. Another thing is it should be placed equally to prevent ischemia, because there are few cases reported about ischemia following these compression sutures. Then comes the modification, that is the Cho square suture. And I think in this diagram, we also saw the 2 cervicoischemic sutures. Then the Cho suture, not routinely, but sometimes if there is a part of adherent placenta, there is lot of oozing we can use. But for this, you need a 10 centimeter straight needle, because you have to go through and through the anterior as well as the posterior wall. Need not be that always we are putting this in 4 places, depending on the oozing or the segment which is bleeding, we can use much simpler method. So the Cho multiple full thickness square sutures applied, time consuming, uterine cavity drainage restriction, so that is the risk of sepsis. There are no feedback data again, and rhythmic contraction is not facilitated and involution may impede. So the production of multiple uterine cyclic may happen. I don't think I can go through this because so the compression sutures, they are quick, safe and effective. They are B-Lynch, horizontal full thickness sutures, vertical full thickness square sutures, and combination of sutures. Now there are data where they have seen that B-Lynch or compression sutures help so much that the success rate was almost 90%, and the other procedures also. So we have to save a mother from pre-PH. Don't forget the critical steps, that is communicate, resuscitate, investigate, initiate the drug therapy, and then last is ligate. Balancing decision is more important. When to reinforce the medical management with surgical management to save the life of the mother, and you never know how close you are. It may be near when it seems so far. So stick to the task when you are the hardest hit, and it's when things get worse that you must not quit. So we have to be really brave, behave like a commander of the situation, and manage everything. Thank you very much. I must share with you that I have been invited as a faculty to again deliver a talk on the PPH simulation in low resource countries in FIGO, and since consecutively 3 FIGO conferences, I am part of a PPH simulation workshop. Thank you very much for patience.